All right, so we'll go ahead and start. Hello, everyone. Good afternoon. Welcome to the Yale Sleep Seminar Series. My name is Ritika Thapa, and I'm one of the faculties here at Yale. And before I introduce today's speaker, just some announcements. Please take a moment to ensure that you're muted. In order to receive CME credit for attendance, please see the chat room for instructions. If you have any questions or comments during the presentation, please use the chat room or take the opportunity to unmute yourself at the end of the talk and ask questions, and I will also moderate the session. Recorded versions of these lectures will be available on YouTube 2 weeks after the presentation. And so I have the pleasure of introducing Dr. Barry Fields today. Dr. Fields received his medical degree at the University of Rochester School of Medicine. He then completed his internal medicine residency here at Yale University just about 13 years back, serving an additional year as chief resident. He then moved to University of Pennsylvania, where he completed a clinical sleep medicine fellowship and a postdoc research fellowship. And during that time, he also trained extensively in sleep medicine and researched its application to remote outpatient settings. He's currently an associate professor of medicine in the Division of Pulmonary Allergy, Critical Care, and Sleep Medicine at Emory University, and is also the medical director of Sleep Telemedicine Program and Outpatient Sleep Medicine Clinic at the Atlanta VA Medical Center, and is also the Sleep Fellowship Director at Emory University. His research focuses on telemedicine-based strategies to promote sleep health in underserved and rural populations. He has received many educational awards and is involved very actively in trainees education. He's also authored many publications and has lectured in courses in sleep disorders regionally and nationally, and has held many leadership positions in national societies. Thank you so much for being with us and being back, Dr. Fields. And without any further delay, I would like to hand it over to you to share your expertise on sleep telemedicine. The genie is now out of the bottle.
Thank you. Thank you so much. And thank you for the invitation. It's so nice to be back at Yale, even virtually. One day I'll be there in person. Just thank you for the opportunity. I am looking at myself on camera now, which is appropriate that it's telemedicine. And I apologize. I would normally have a tie on and be a bit more spiffed up. This morning, I ran out of the house because we now have tropical storm and hurricane warnings and all this kind of stuff in Atlanta. And we're getting ready for Hurricane Camille tomorrow, which is a perfect opportunity to utilize telemedicine actually to keep our services running. So with that, I'm going to go ahead and get started. Let me just bring up my screen here. And this is the information for your CME disclosure and accreditation with the number to receive your credit if you want to take a quick shot of that. These slides, I may or may not get to all of them. Because we want to have a little time for questions. So I've also provided them to Debbie so that they can be distributed and they can go out there. So the learning objectives for the next 45 minutes or so, hopefully at the end, you'll be able to define terminology related to various telemedicine modalities and describe current telemedicine feasibility through different lenses. When people say, is sleep telemedicine feasible? Well, what do you mean? From what perspective? Through what lens? And then throughout the presentation, hopefully I'll be showing you resources to use for reference for successful telemedicine implementation. So let's go back to 2019. This was in the ACP Internist, and I believe this is the publication that's now called IM Matters. And January 2019, is telehealth ready for prime time? And it sort of was. They said in the paper that as payers, private and public, begin establishing guidelines and paying for these services, most expect this area to explode in the next year or two. And little did they know there would be such a major disruptor called COVID in the next year. And so it did indeed explode, maybe not for the reasons that the ACP thought. And so when the pandemic first hit us, this is from the former CMS administrator, Seema Verma, quoted in the Wall Street Journal. In the first month or two of really when the pandemic hit, she said, and this is where I got the title of my talk from, I think the genie's out of the bottle. I think it's fair to say the advent of telehealth has been completely accelerated. It's taken this crisis to push us to a new frontier, but there's absolutely no going back. We've been doing telehealth at the Atlanta VA since 2014, and we would tell people about it. I'm based mostly here at the Atlanta VA. Visin 7, for those of you who speak VA. And we were talking about it, we were doing telemedicine, and it just wasn't catching on. And then it took a pandemic. So the kind of patient who really benefits from telemedicine is a patient like one of my patients from a few years back, Mr. M. And Mr. M is 78 years old. He's a veteran with diabetes, hypertension, and chronic back pain. He had years of snoring, unrefreshing sleep, and witnessed apneas during sleep. He is obese, a large neck size, hypertensive, and he's sleepy. Epworth of 18. And so just to show you what Mr. M used to have to do. So this is Atlanta. So Atlanta's in North Georgia, just to show you a little geography. We are a couple hours from Alabama, less than a couple hours, like an hour from Alabama. So the time zone changes quickly. Tennessee, North Carolina is nearby, South Carolina is nearby, and Mr. M lives in Blairsville. Blairsville is in the North Georgia mountains in the Chattahoochee National Forest. It's beautiful. You'd think you were in the Adirondacks or the Connecticut River Valley up in, heading toward Dartmouth and all that area. It's really pretty. But it takes over 2 hours each way through these twisty mountain roads to get to Decatur. And Decatur is our sort of suburb where I am physically now, here in Atlanta. And you may hear we're getting some thunderstorms. So I apologize for that. It's getting very tropical here today. So this was his wild ride. And we're telling this tired 78-year-old man, yeah, drive down here. I'll see you for like maybe half an hour and then drive back. And I expect you to be safe and happy and get back home. And then I'm going to have to drag you back for each follow-up visit and all that. Not optimal. So COVID-19 really pushed us to use more telemedicine, and this is what we had used for Mr. M. And just to show you the impact of the COVID-19 pandemic on sleep medicine practices, in black is before the pandemic. On the y-axis, I don't know if you can see my little pointer or not, but the percentage of virtual visits was mostly 0. Very few people were doing virtual visits. Some were doing a few. Once the pandemic hit, and this was published in 2021, so in the first year after the pandemic, you see the gray bars, which are shifting to the right. Almost every practice was using some form of telemedicine. And while I suspect there may have been a little bit of a shift to the left again, it's not as far as it was back before 2020 here in black. So sleep telemedicine is still being used a lot throughout the field. So it's important for us to understand terminology. So if many practices are using telemedicine in academics, in the VA, and privately, we should all be speaking the same language. And I'll show you later how this also is important for research. So you hear these terms: telehealth, telemedicine. So telehealth is a general term. It's the use of electronic information and communication technologies to provide and support healthcare when distance separates people. Telemedicine implies a direct patient to provider interaction. It's actually a legal term. So telemedicine is the medical care. We could say that this is telehealth, where we're talking about supporting healthcare right now, but we're not doing telemedicine. And sleep telemedicine is the use of sleep-related medical information exchanged from one site to another via electronic communications to support a patient's health. As you'll hear, it could be on the phone. That's technically telemedicine. It could be over video, but sleep telemedicine is just this subset. And so synchronous telemedicine, these terms are really important because when we talk about research, when we talk about insurance coverage, they may not cover your patient unless you know that the visit needs to be done synchronously. Real-time video audio telecommunication, which is also called clinical video telehealth, or CVT, just like we're doing now. This is a version of synchronous, we could say synchronous telehealth, because we're talking in this way. Asynchronous telemedicine is the non-real-time provision of care. So it's the store and forward, CPAP downloads. In ophthalmology, it's the retinal imaging. It's telemedicine, but it's asynchronous. It's not seeing the patient on video at the same time. Telemedicine is patient-oriented. Your session does not originate with you. It's your patient. So the originating site is the location of the patient. The distant site, and these are actual terms, is you, the provider. This means a lot when we talk about licensing. What if your originating site, meaning the patient, is in a state where you don't have a license? You can't take care of that patient. Doesn't matter where the distant site is. It's the originating site where the patient is. So knowing this terminology is very important. The originating site, you better make sure that you are doing the visit legally because you're licensed there. And of course, you're going to get paid for the visit. I talk about payment and I'll talk more about insurance. The point of sleep telemedicine is not to provide necessarily higher quality care. We're trying to maintain the quality when distance is an issue or patient disability is an issue or something like that. We're also not looking for a cash cow here, right? We're not focused just on how can you make more money. But the fact is we have to talk about, we will talk about the finances, because if you can't get this visit paid for, you can't have a sleep center. So this is all very important. So when we think about modes of care terminology, so there's on top the traditional care, in-person care. Then there's the C2C model, center to center. The provider, the practitioner is at a medical center, and the patient's at a medical center, just not at the same medical center. This is what we used to do for years in the VA system until COVID. Then we moved to a center to home model where I'm in the medical center, it's the center, but it's to a patient's home or workplace or something like that, which, as you can imagine, brings its own set of challenges, but that's C2H. And then there's OOC. So tomorrow, Friday, we have already extended maximum telehealth flexibility to our staff here at the Atlanta VA Sleep Center, because at least as the day goes on tomorrow and into Friday, it could be quite dangerous driving around here with winds and rain. So tomorrow and Friday, if at all possible, we're doing OOC. I have clinic Friday morning. I will likely be at home. So OOC will be, I can still maintain my clinic. The patient is at their home and everybody stays safe. So a summary of that terminology: telehealth is the larger world here. Telemedicine is a specific patient visit. Sleep telemedicine is as it applies to sleep medicine care. And CVT, clinical video telehealth, telephone, modems, asynchronous. These are all parts of sleep medicine. And within CVT, clinical video telehealth, depending on where you are, depending on where the patient is at the originating site, it's that C2C or C2H or OOC, out of center model. So just to review a little bit to make sure we're all on the same language page with the terminology that we're going to be talking about. So we did the terminology part. Hopefully you're a little more familiar with that. And again, I provided the slides for you to review later. And I know this is being recorded as well. I want to next talk about feasibility. People ask me, yeah, but is it really feasible to do? And that depends what lens you look through. And again, I want to be clear. I'm not claiming that telemedicine is better care. I'm claiming that it is a useful tool that can be used, but like any tool, it can be used inappropriately. But when used well and in the confines of insurers and like the law, it can be very effective. That's my viewpoint. So this is our old telemedicine cart, and one lens you may want to look at to say, is it feasible? Well, is it technologically feasible? So that's one lens. Another lens, what about clinically? What's the point of doing this if we're not able to achieve at least equivalent clinical outcomes? Why would anyone do telemedicine if it winds up not helping people or even harming people? Finances, as I said, we'll look at that. We'll look at some licensing through the lens. Is it feasible? We'll talk about regulations as well. So I'm kind of hitting upon the second and third learning objectives at the same time. The second objective is feasibility and the content. The third learning objective was about resources. So on each of these slides, I present some resources that you can look at for more information. And so these are the technical requirements for sleep telemedicine, laid out first in 2015 by the American Academy of Sleep Medicine, and then again in 2021 by an updated telemedicine work group. And full disclosure, I was on the second work group, but my presenting this does not result in any sort of payment or monetary benefit to me. So that's just for full disclosure. So when you look at the technology, they specify the American Academy of Sleep Medicine, the bandwidth and resolution. You don't want a horribly pixelated screen, and most software allows this. So it is technologically feasible. The diagnostic equipment is optional, but it's nice, especially if you're doing a C2C model and a patient is in a distant clinic. A tech can help with an electronic stethoscope. We used to do a lot more of that actually at the VA. You can also plug in a camera. This is actually a picture of Mr. M. On this electronic camera. I can actually see into his mouth. It's not a perfect exam, but it convinced me that even when he put his tongue back in his mouth, he has a class 4 modified Mellon-Potty airway. So you can do somewhat of a physical exam. It's not the best through telemedicine, but if you have to, it's there. And I didn't pull Mr. M all the way down here just to tell him that that he has a crowded airway and needs a sleep study. So when we followed up on his follow-up visit, we had already done a home sleep apnea test and found that his AHI was 51, or I should say the REI was 51 on his home sleep apnea test. But now we've had him on CPAP and we were able to do this remotely. The veteran learned about the machine on camera. We sent him the device and we can monitor his device remotely. That doesn't work well for everybody, but for motivated veterans like Mr. M, he was so grateful not to have to leave home that we were able to troubleshoot. And he's an example. He's not alone. I didn't just cherry pick. He's doing great. His Epworth is much down now, cut in half. He's not snoring, which makes his bed partner very happy. And each visit saved 190 miles for him. The VA often will reimburse travel. So this also translates into savings to you as a taxpayer, that we're not spending as much money reimbursing folks for travel if we can get away with telemedicine. And in this case, now we're doing it to Mr. M's home. So the VA is really controlling costs that way while still maintaining the quality of care. And I'm sharing my screen with him on the left, and I'm sharing, he has a ResMed device, and I could show him that he's using the device nightly. His adherence data is great, and this treatment of sleep apnea is beautiful. So I can see that we're achieving our clinical outcomes with this veteran, and we do it time after time. So is it technologically feasible? Yeah, it's not perfect. If you have concerns about the physical exam, the person needs to be seen in person. But for the kind of visit that I showed you, it's very feasible. Let's move on to clinical outcomes. And I want to show you a little bit of research that I've been involved with and others have done, which again, I think argues that if you do telemedicine well, we can at least achieve equivalent patient outcomes. So this was a study I was involved with when I was doing my postdoc in Philly about 10 years, 12 years ago now, I guess. And it was called RAMVO, Remote Ambulatory Management of Veterans with OSA. And it was a prospective randomized pilot looking at the feasibility of a comprehensive tele-based pathway with phone and CVT and modem. We had 60 veterans who were being newly diagnosed for OSA. We looked at their functional improvement, which was the primary outcome measure using the FOSQ questionnaire, FOSQ, and symptoms, satisfaction, PAP adherence, as well as dropout rates. And we look qualitatively at the acceptability and their feedback as to what they thought of telemedicine. And this went into sleep in 2016. So basically, we had veterans come into 2 outside VA clinics. Either I traveled to the clinic to see them in person, or they saw me over video from Philly. In either case, the veteran always traveled to their clinic. The only difference was, did I see them over video and monitor them remotely, or did I see them in person and keep having them bring in their device for a download? And the modems on these units were new at the time. So remember, this is like 10 years ago when the AirSense 9s were becoming AirSense 10s. We were using ResMed. And in terms of the primary outcome measure, which was changes in that FOSQ score, essentially it was a very small study. We were just trying to show feasibility, and there was really no difference. There was no inferiority if you were in the tele group. This study, again, was set up for feasibility. It was just a pilot, but at least it encouraged me to look more into telemedicine and ultimately bring it to Atlanta. So you can see here that after I think this was 90 days of PAP use, neither group did that much better in terms of their functional outcomes, at least on the questionnaire. Because you can see the whiskers crossing 0 there. However, there was no significant difference. If anything, the telemedicine group showed a small, non-statistically significant improvement, that more so than the in-person group. But the point is the p-value is 0.06, and so we really didn't see much difference between groups. There was no difference in terms of patient satisfaction, dropouts, or PAP adherence after 3 months. And some of the feedback we got in the qualitative part of the study was that a veteran said, I don't think CBT was any different. Like I said, he was there. We were talking face to face on video. The only difference between talking over video versus to the doctor actually is, they're in the office. They're there in the office. And one person I enjoyed called me the TB doctor. And again, this was pretty new at the time. So this data was generated 2012, 2013, 2014, so well before COVID. So that excited me that at least we could do it. It was a proof of concept. And so when I look at other research that's been done in the world, let's say of insomnia, this was a study, oh gosh, I think it was out of Michigan, also published in Sleep. And they provided veterans, or I guess, I don't think this was in the VA, they provided patients with cognitive behavioral therapy for insomnia, either through telemedicine over video or in person. And again, it's really important to learn the terminology, because a lot of these different research studies that claim telemedicine is equivalent or telemedicine is better than in-person care. What do you mean by telemedicine? Do you mean telephone? Do you mean on video? Did you call the patient every week for the study, which we could never replicate in a clinical environment outside of research? So it's important to know what they mean by telemedicine, but it was pretty close to what we did in Philly. Then you can see here they allocated people, 33 people to the telemedicine arm, 32 people to the face-to-face arm, and they followed them for 12 weeks post-treatment with the CBTI. And they found when they looked at right after treatment and after 3 months, the insomnia severity index was the primary outcome measure. It didn't matter. It just didn't matter whether people completed CBTI through telemedicine or in person. The improvement was about the same. And you can see that it did not meet it was within that non-inferiority margin. So telemedicine did not degrade the quality of the treatment. And then this was one of several studies actually that have come out in the last 5 to 7 years looking at, this is a meta-analysis of studies, and you can see the years there from 2006 all the way up to, it looks like 2019 here. And these were all studies that looked at PAP adherence. Do patients with obstructive sleep apnea appear to adhere to PAP therapy even worse if you do telemedicine or in person? On the left-hand side here would favor the control. On the right-hand side would favor telemedicine. If anything, telemedicine-based care led to better adherence. There's a lot of heterogeneity. These studies define telemedicine differently. The protocols are different. They can be very, staff heavy because they had a research staff calling patients every week. So take it with a grain of salt, but there is not a signal that is concerning that maybe adherence is worse in telemedicine. These are 2 slides from the same paper. They looked at 3 months, they looked at 6 months. Again, the effect held up, and people will worry, well, what about older individuals? They can't do telemedicine as well. It didn't matter on the right-hand side, whether you look at 50-year-olds or younger or older than 50, both groups showed, if anything, slightly better results in terms of PAP adherence through telemedicine. This was work done at Washington, University of Washington out west. This was a qualitative evaluation of a group of individuals who were participating in telemedicine, but using the different styles I talked about, either C2C, center to center, or center to home, where the patient's at home. And also there was a telephone group. The N is small, a dozen people or so in each group. but it's kind of interesting. So when they asked them specifically about, all right, what were your experiences with telemedicine? And again, this is intra-pandemic. During pandemic, how's it going? I think actually the study started before the pandemic, and then the pandemic actually kicked in mid-study. So the pros, people felt that it improved their access to care and specialists, the efficiency of care, no travel, COVID-19, of course. It was an alternative to community care. In the VA system, you may be sent out to the community, and it's hard to sometimes find out what the community doctor did. Whereas here, they were kept in the VA and through telemedicine, and therefore it worked better for them. Safety and security, they felt secure in their own home. And for a lot of veterans, especially, it helps avoid the triggers. Traffic, loud, lots of people, big medical center, they can stay home. The cons, of course, there's a flip side to this. There is some limited privacy if a family member keeps circling around behind you while you're trying to do the visit. Maybe a less personal relationship with the doc. It's hard to fit masks through telemedicine or ask for PAP machine assistance, and there's no physical exam. So all the factors that make sense were also brought up as concerns, and some of these are changeable and some are not through telemedicine. Let's talk about finances. So in terms of, so we went through that it's technologically feasible, and I think clinically it's feasible in terms of outcomes. I want to talk about finances. So is it financially feasible to use telemedicine? And I have this picture of a fish, which is a wide mouth bass, which is the state fish of Georgia. And it is to remind me to tell you that it's impossible through the next series of slides for me to share every fact that relates to what you need to know about telemedicine from any of these perspectives. But I'm trying to teach you how to fish rather than giving you a fish. So this is another example of a resource which is extremely useful, the Sleep Telemedicine Implementation Guide, which is up on the ASM site for ASM members, and it's freely available. And there's a whole table of contents that you need to know to think about how to frame your questions if you are conducting a telemedicine visit, for instance, or a telemedicine clinic. So for instance, there's this cost analysis worksheet. If you're considering, and this is for practice management kind of decisions, should we just keep doing satellite clinics in person and travel? Should we do C2H? Should we do C2C? And I added a column, should we do OOC, out of center? Basically, you'll look at revenue, how you're going to pull in revenue from each of these clinics. You'll look at monthly costs, not always applicable, like, I don't know, staff travel. If you're doing C2H or C2C, you don't really worry about staff traveling. If you're doing an in-person satellite clinic, you may need your techs to travel too. So that's a cost of time. And basically, you total up all the costs, you total up all the revenue, and it's a tool to help you think about, will I be able to make it with this telemedicine clinic? Does it save me money over in-person care or not? And basically, like any economic analysis, you have to have income from grants, patient visit reimbursements, sleep testing reimbursements, and it has to outweigh expenditures like equipment, licensing fees, clinical space. Do you have to rent space at a different clinic to do a telemedicine visit? It's a lot cheaper if the patient's at their home or office, so you're not taking up space elsewhere. You may have to advertise that clinic, especially in the private world, and there may be lost in-person revenue while you're setting up and getting going with the telemedicine clinic. Thinking about the feasibility of telemedicine then from a financial perspective, well, I'm not so great at this. Some physicians are better at business than I am. I'm not, but we have to think about it as a business. And what are some sources of reimbursement? Well, we have private insurers. Will a private insurer pay for telemedicine? Medicaid, are they going to pay? Medicare? And then there's, of course, out of pocket. Will patients pay out of pocket? The key is this, and there's no way I can cover it all, but you have to know the regulations for both your state, which is the distant state site, and the patient's state, which is the originating site. It may be both Connecticut, which is fine. It may be, and I know some of you folks are from outside Connecticut and all over the place. I saw Caribbean, I think, as well. So you can see that you have to give consideration to a lot of different factors. So let's talk about private insurers. There are parity laws. This is a map as of 2023, and I won't go through all the text. I left the resource from the AMA. These are for video visits. Typically, the states specify it has to be real-time synchronous care. The states in purple have payment parity. So I'm in Georgia, you're in Connecticut, fantastic. And you can see many Western states as well require private insurers to pay the same, whether I see a patient through video telemedicine or in person. But there are a lot of states that don't have that. Right next door in Alabama, they don't have that. So if I'm doing video telemedicine to patients there, there's no guarantee that a private insurer would pay for it. A great resource is the Center for Connected Health Policy, which is part of the National Telehealth Policy Resource Center. When I was preparing for this talk and tweaking it this weekend, I try to throw some Connecticut stuff in here. So you can compare. What does the private payer law look like here in Georgia? What does it look like in Connecticut? And it will specify the details. What does payment parity mean in each state? What kind of visits must be carried out to qualify for payment parity? And so CCHP is a great resource for that. So that's just a little bit about private payers. You got to do your homework. For Medicare, pre-COVID, it would only pay if the originating site where the patient is in a health professional shortage area outside of a metropolitan area. It had to be real-time CBT, and it was ineligible if it was C2H. If you're going to a patient's home, except in certain circumstances, but for sleep, Medicare was not going to pay you for that. And if it was asynchronous, they weren't going to pay. That's changed. So coverage was broadened on a temporary and emergent basis through 2023, and I will add there's a fact sheet at the bottom there. It's been extended at least through 24 with some caveats. So now Medicare can pay if the patient's originating site is at their place of residence. That started during the pandemic when things really were opened up, and providers can also bill for direct supervision through telemedicine if you have a resident or something like that. And there are certain types of virtual services. I could go into this in a ton of detail, but Medicare now has become much friendlier to telemedicine. The question is, they have actually extended through the end of 24. Will they go further? Right now, there have been no geographic site restrictions. In the next few days or weeks, we expect to hear what is going to go on long term. They've even been covering some audio only services. Again, it all comes down to knowing, doing your homework. And the same is true. I go back to the CCHP site, Medicare and Medicaid. The rules are different. And so there's Georgia Medicaid, with some limitations. Connecticut Medicaid is required to cover telemedicine services for categories of care that are listed. Very important, though, that you click on, there's a link there. If you look at the Connecticut page with the CCHP, there's a telehealth information page with FAQs, and you can look more about the hoops that all of us need to jump through at times, including in Connecticut, to make sure that we will get reimbursed for those visits. And this is just an example of the Connecticut Department of Social Services. I literally just screenshotted it just to show you. This was from Sunday when I was putting this together, Sunday night. That Connecticut has a ton of resources, including a telehealth table, which shows you those services that are covered from the different payers in the state of Connecticut. So just really important for you or your facility, whomever, to be doing your homework to ensure that these visits are treated the same as in-person visits should you choose to pursue them. Let's talk about licensing. This is where you're going to get in trouble. If you don't pay attention, distance site providers must be licensed in the originating site's state most of the time. So in other words, if you're in Connecticut and I'm in Atlanta, you can't be taking care of me through telemedicine unless you are licensed in Georgia. Now, I say most of the time because if you're in, like I'm in the VA system, I have a Georgia license. I can practice anywhere. I could technically have kept my Connecticut license. I let it lapse, but I could have kept it and been practicing here in Georgia for the last 10 years. It really doesn't matter. But if you're outside the Fed system, it does. And so to make the process easier, if you are seeing patients outside of your state, there is this interstate medical licensure compact, which is endorsed by the ACP. So basically how it works is this, is let's look at the states in blue. So if I'm in Nebraska and I want to practice medicine in Kansas, I still have to pay for my Kansas license. I still have to pay this compact to ease the process, but it is a time saver so that I don't have to spend all that time starting from scratch in Kansas. I can use my Nebraska privileging and licenses, and for a fee, plus the licensing fee, the Interstate Medical Licensure Compact will ensure that you get licensed quickly and efficiently in Kansas. The states that are part of the compact have grown over the years. Connecticut is partly part of it. That's why the color is kind of a lighter blue, but I think is working toward fully becoming part of the compact. And it doesn't save you any money. It costs you money, but it makes it a heck of a lot easier, from what I understand, to gain licensure out of state if you go through the compact. Regulations wise, I'm going to go back in terms of a regulatory perspective. I showed you this table before. It was, I would say, telemedicine is feasible from a licensing perspective as long as you follow the rules about being licensed in a particular state and potentially using the compact. Privacy and security, you have to make sure that your software is up to date with the latest security updates, and you need to make sure that it's HIPAA compliant. And so as long as it is, from a privacy and security perspective, it should be very feasible to do. There's some general medical legal ideas to keep in mind. Treat these visits like any in-person visit in terms of continuity of care and HIPAA and documentation. Know your local requirements. Check with your malpractice insurer if you start doing telemedicine. There is no guarantee that your malpractice insurer will cover it. So again, you don't always think about these. I anyway, don't always think about these questions, but if you don't think to ask them, no one else may. So that's very important. And some states can restrict the testing that can be ordered, like home sleep testing, without an in-person visit first. So you have to know that. And we already talked about licensing. I would say this, and I put a paper which is now from 10 years ago in CHEST, but I think it's still useful. And actually, 10 years ago in this Sleep Review magazine, and then CHEST from 2018. If you are sloppy as a doc in person and you're sloppy as a doc doing telemedicine, you could get sued. However, if you follow the rules and regulations and you're a very careful professional doc or other practitioner, you should be fine. There's never been a successful, as far as I know, malpractice lawsuit simply because it was carried out over telemedicine. Controlled substances are tough. So there was this Consumer Protection Act, Ryan Haidt, in 2008, where you could not prescribe controlled substances unless there was an in-person visit. That's actually been in place for a while. People didn't always realize that. There's been a telemedicine exception in the works going back to the Obama administration, and it's still, no matter who the president is, never seems to be able to get through. The process is pretty tough usually, and I just show this. This is from the DEA, that ordering a controlled substance through telemedicine could be rather complex. You are asked to evaluate the patient in person. Now, during the public health emergency, it says, or using telemedicine. The public health emergency has expired. So what is happening now is that the DEA has extended telemedicine flexibilities through 2024, and it's up to the states to determine, apparently, if they're going to follow that. So there was a bit of a scare here in Georgia early in 24, where we thought any veteran who was, or anyone on a controlled substance that if I hadn't seen them in a year or two, I would have to haul them back in here before I could prescribe them a controlled substance, such as a patient with narcolepsy who's been successfully treated for years through telemedicine. Do we have to pull them back in now to see them in person? I couldn't find the current guidance for Connecticut, but I will show you for Georgia. This is from the Composite Medical Board. They've been going back and forth all year. Finally, now they've basically said, board rescinds the decision to end the teleprescribing flexibilities allowed by the DEA. So basically, there are a couple double negatives in there, but at least through the end of 24, Georgia is allowing me to prescribe controlled substances, having only seen the patient through telemedicine without my seeing them in person. If they want to be strict about it in 25, I, as the prescriber, will need to see every single of those patients in 25 somehow in the midst of my schedule of other patients and their travels, or else I have to cut them off. We hope that these flexibilities will continue, and it really has to come from Congress, and all of you know that that's often quite tough, but we'll see what situation we're in just in the next few months. And the Center for Connected Health Policy has further information about online prescribing, and they've kind of updated that no telehealth provider shall prescribe any Schedule 1, 2, or 3 substance through telehealth, except in certain cases, and it's very complex right now. So check with your employer as to what the current policy is and go by that, but it's kind of a mess until there's some unified national policy. So I've talked about feasibility through these different lenses: tech, finance, clinical, licensing, and regulations. I want to throw in teaching as well. A lot of us are in teaching institutions, and we get questions, well, how feasible is it to be training people in a fellowship or residency using telemedicine? And so one of our questions is, how much exposure are our trainees getting to telemedicine? And so this was a survey that we did, just came out earlier this year. We did a survey of sleep medicine fellowship program directors in 2019. And we wanted to see how much telemedicine was being used in sleep fellowship training. And we said, we'll repeat it in a few years. Well, serendipitously, a COVID-19 pandemic hit right as the paper was coming out. So in 2022, 2023, we repeated essentially the same survey, which is here. We contacted 91 fellowship program directors and 41 completed the survey. So it was a pretty good response rate. 40 of the 41 offer sleep telemedicine. I'm going to show you, compared to several years before that, was a sleep telemedicine experience a standard part of your training program prior to the COVID-19 pandemic? Only 20% of people said yes, it was. Most people, 80% of those program directors, said that before the pandemic, there was no exposure to telemedicine among the fellows. So we graduated a lot of fellows in the last decades who really had very little training in telemedicine. As you've seen from my previous slides, it's not as easy as just getting in front of a camera like I'm doing and talking to a patient. You really need to make sure that you're doing it legally and that everything, the whole system is set up for those visits to do it properly to avoid trouble down the road. So a huge shift in the use of telemedicine over just the past few years. As I said, it was a serendipitous post-COVID survey before and after the pandemic. I find teaching with telemedicine can be very helpful. This is an example of a patient, and we're learning about retrognathia. And I don't do enough physical exam teaching anymore with our sleep fellows, and they do probably around half of their clinics are telemedicine at Emory and the VA. Peds are in person. And here we can learn about retrognathia. You have to, if you don't see as many in-person patients, you find a way. And so we did a retrognathia evaluation here. There was no retrognathia noted. So teaching, as we talk about teaching, it's not just about teaching about telemedicine, it's teaching sleep content through telemedicine. And we have to think about, especially like when I have fellows with me in clinic on Friday and I'm at home with the hurricane, how am I still going to make sure that I'm teaching these fellows so that they get the learning experience despite not being in person? We teach them about their website manner, like the teleprompter effect. If I'm doing my presentation and I'm looking at the slides down here, it's very hard for me to engage with you. But if I know that I'm looking at you and I'm reading the slides that are, or the patient's face may be close by the camera, it doesn't feel as off-putting. It looks like I'm looking at the patient, and that can be very useful. We want to avoid the telemarketer effect where there are people behind me and there's a lot of noise and the patient's like, is this private? Are you even paying attention? It's so loud. It's kind of loud here now because we're currently, again, getting a bit of a monsoon. The background matters. I purposely did not blur my background today or anything. So you can see that, I have a printer back there. I have my little certificates back there. If it's distracting, you may need to change that and blur the screen, and beware the screen share. So sometimes stuff will pop up that you don't want the patient to see. If you're screen sharing with them, I show patients masks and I show them their adherence downloads. Just be aware of what other screens may be up and don't screen share what you wouldn't want to screen share. There's a great paper that came out a few months ago, from a few years ago now, from Minnesota, Dr. Irfan and others out of Minneapolis, showing the process of a supervised telesleep encounter. Is it reasonable? Sure. I mean, they kind of have swim lanes here, which show you how the visits are conducted by trainees. Is the supervisor on site? If not, they can still discuss the key findings of the plan. I do this commonly. I will then jump into the patient's virtual room with the fellow and finish up the visit together. Is it perfect? Is it as good? I don't know. But we make do because telemedicine is here. It just is. And I think we do our fellows and other trainees a disservice if we try to avoid them participating in telemedicine. We also worry about making sure we follow Medicare rules. So typically Medicare patient payment is made for services furnished by a teaching physician only if the physician is physically present for the key part of the service. During the public health emergency, that was relaxed. And it's still relaxed through the end of December of this year, exercising enforcement discretion. We've been dealing with this with Emory, who looks to CMS for funding a lot. It's going to be interesting the next few weeks or months. We may have to change some fellow rotations over there if we have to figure out a way to have them see patients on days when a physician is actually in the office. Many of the physicians have changed up where they are for what clinic because of the telemedicine flexibility. So we'll kind of see how this all shakes out. The third learning objective here, I've kind of been showing you throughout the talk. Identify important resources for successful telemedicine implementation. And I kind of listed them here. There's the American Telemedicine Association and the American Academy of Sleep Medicine. And I showed you some resources from them, as well as the AMA and CMS. Very important. You can look at their telehealth resources for all the current stuff. I could only biopsy some of the information that's there. I showed you quite a bit from the Center for Connected Health Policy, CCHP, very, very useful. I threw on here the Connecticut Department of Social Services, which has more telehealth and telemedicine education for you all locally. That's the medical licensure compact I spoke about. And then national guidance is from HHS, Health Resources and Services Administration, through Health and Human Services. So the bottom line, and I want to kind of wind down because I'd love some time if we have for questions or any discussion. The bottom line is telemedicine is a useful tool to improve limited healthcare access for various reasons. Immobility, horrible weather, like we're already starting to have, distances, all of that. But like any tool, careful consideration is advised to use it wisely. A screwdriver is a great tool, but if you need a hammer, the screwdriver is not going to be useful, and you need to know when to use it or not. So I don't want to leave you feeling that I'm saying telemedicine is going to save the world here, but I do want you to know that it's very useful. And the fact is, it's here. Whether we like it or not, I don't always love telemedicine in every encounter, but the fact is it's here. And our patients more and more are expecting it. They're asking for it. And it behooves us, as I said earlier, to make sure our fellows are trained and that we are trained as well to be as successful sleep telemedicine practitioners as we can be in the rapidly changing practice landscape. So that's it. I tried to update you as much as I could. I tried to provide you as much of some of the evidence as I could that's out there. And I'm going to stop and see if there are any questions or I can help with anything else.
Yep. Great. Thank you so much for this excellent and very thorough presentation on this fairly new topic. It's really exciting to see telemedicine. But let me ask you a few questions that I have here in the chat room, and then I'll ask you a question. First question is by Dr. Mann. Is the originating site based on the patient's home address? What if they're on vacation out of state?
That's a great question. So this is where it gets a little bit murky. In general, it is safest to assume that the originating site is where the patient is physically located currently. So I'll give you an example. We have patients in Alabama. I know Emory has patients in Alabama. Alabama is only about an hour from here. It's not far. Patients, especially if the Emory provider is not licensed in Alabama, most are not, but the patient still wants telemedicine, you know what they do? They drive to the first rest stop on I-20 over the border in Georgia. The patient's home address is still in, Birmingham, Alabama, but the patient is in Georgia. That's the originating site, and Georgia will cover that visit. So in general, it's where the patient is right now.
Thank you. And then there's a comment, TRICARE covers people leaving active duty for 6 months.
It does, yes. So that can help if it's under the federal system. The originating site can be anywhere. I think, though, it has to be, on U.S. soil. That is often a limitation. So just be careful if they're on vacation in Cancun. But if they're on vacation in Charlotte Amalie, U.S. Virgin Islands or something, that's okay. If they're in the federal system, at least for while they're covered under the federal insurance, just make sure you're clear on that.
Thank you. The next question, if the vet moves to another state in the first 6 months, will telemedicine still be valid?
Yes, I think that goes, yes. So if you can still, if they're in the federal system and you are practicing under that guise, you should be fine. After those 6 months, though, if the patient is, I guess their veteran is no longer in the federal system, as far as I know, if you're using private insurance or any other healthcare system, the previous rules I discussed apply. So maybe for the first 6 months, if they're okay, if they're in Alabama and you're using the federal system. But after that, you need to be licensed at the patient's originating site in order to care for them.
Thank you. The next question we have is from Dr. Mohsenin. Should telemedicine encounters be recorded as part of a patient's medical record?
Absolutely. So it's a great question. The default is that telemedicine may be special, but it's not that special. You treat it just like any other visit. However, it's important that you be careful how you put it in the record. I'll give you an example. In Georgia, if I have a patient where I the patient lives in Georgia, I'm in Georgia, everything's fine, I'm licensed, and I want to use Georgia Medicaid. Georgia Medicaid has rules that the patient must sign a consent to do telemedicine before you can do a telemedicine visit. You need to document that consent was provided to ensure that if your charts get audited and Medicaid, if I said Medicare, I'm sorry, I meant Medicaid. If Medicaid comes back and says, we're not paying you for this visit, you can say, well, here is the permission, here's the documentation, and yes, it is okay. So that's where it's important to know your state and document what you need to document, but telemedicine visits should be part of the medical record, treated just like any other visit. When I see a question about the blood pressure, that's a good question. We've run into this actually. So if the patient, depends on the model. If it's C2C, then a technician or nurse or a medical assistant at the other center can get the blood pressure for you and report it to you. Little tougher if it's OOC or C2H because the patient does not have access to someone. What we have actually done, I just had this come up with a couple of my patients. We're trying to do better about checking blood pressure, especially on patients who are on stimulant therapy. Maybe they have idiopathic hypersomnia or narcolepsy. So at least I know the VA will send patients a portable cuff. And I've done this a couple of times where the patient, we walk through it, they get the little booklet, they know how to do it, or they can go to their local clinic and learn. The patient actually on like under observation, I see them checking their pressure and they just show me on camera the results on the device. Again, I'm not saying it's as good, but that is one way to be able to record blood pressure, especially for folks that are on stimulants. So that's how we do that here. Or, and also I should say, okay, it's one thing, the VA sends devices out and that's great. Outside the VA, usually blood pressure devices are relatively inexpensive to obtain through drugstores or other sources. And so that's basically what we do.
We have next question from Lakshmi Polgiseti, which is shared medical appointments seem great for obesity patients. Is it also a good option for sleep patients via telemedicine?
Let me just finish up the response to Dr. Mosinin, because now I see what his question was, which is another great question, meaning should the video be recorded? Like
Oh,
we're
yes.
recording the video now. So generally it's discouraged just because if there's any concern about privacy, in other words, you wouldn't record an in-person visit with the patient, right? So generally we wouldn't record a telemedicine visit with the patient, no. So again, I would kind of put yourself into that mindset of if I don't do something in person, I don't record them, I wouldn't record their telemedicine visit either. And for shared medical appointments, very good question. I think it's great. We've had shared medical appointments here. We struggle because every person has to have the same link, and if they don't get all the right links and they can't sign on, sometimes a group is a little bit more difficult. But it's a fantastic idea. I've seen it work best, and everyone is different. I've seen it work best in the veterans, and again, I work in the VA system, but veterans, there's a very strong social connection. And if you have 6 veterans together and 3 veterans are really suffering and trying to use their CPAP and struggling to adhere, and 3 veterans are doing really well and adhering to CPAP, that is an incredibly strong kind of social pressure. Hey, let's help each other. And usually the veterans have better suggestions than I have. And so if you're able to do a group, a shared medical appointment, and make that work, I think that is a wonderful tool. It can be done through telemedicine. It just gets a little dicey if like one person is struggling to get on and then they call you and I can't sign in and I don't know what to do. I didn't get the link. It can degenerate. But I think it's a great use of telemedicine if you could do it.
Thank you.
Thank you.
Are there any questions? Anyone? You can unmute yourself. I had a quick question. So, we know that there is visibility of telemedicine and sleep medicine in so many ways, especially the exam part. What will you do just with the Mullen Putty? Anyway, you are getting the sleep study. And if there is payment parity in states, why do you think institutions are going backwards to in-person rather than telemedicine visits, since it's uptrend in COVID? And then what are your suggestions, to move forward again with telemedicine?
Yeah, it's a good question. I'm being a little bit cynical in my answer, which is that very often if you follow the dollars, things make more sense. And so as an institution, if they feel that, the rules may be changing soon, we may not get our visits covered anymore, we better pivot back to in-person care now. When I was a fellow 10 or 12, whatever years ago, when we quickly had to pivot from PSGs to HSATs, places closed. They couldn't pivot fast enough, and you saw labs shut down. I'm not saying this is exactly the same, but it's a similar idea, which is that we could have to pivot at the beginning of 25. We better do some of that now. And there are questions about, licensing is annoying and those kinds of questions that come up. But I don't know. I don't mean to be flippant, but that's why my answer is kind of, if you follow where the money goes, I don't think they're focusing on, I'm just being, I don't think they're comparing efficacy data here. I think it's really preparing for a shift. What we really need are national permanent policies that guarantee the funding for telemedicine visits with caveats, with the rails on, with some rails on it, and national policy for telemedicine-based prescribing of controlled substances. Again, under certain circumstances. I'm not saying just throw it out online and give, Adderall to everybody.
Right.
But if we see permanence in these changes and not just this kind of vacillating response, I think you'll see telemedicine hanging around a lot more. But even Emory, they're getting scared, and I understand. So hopefully that kind of helps.
Yes, no, thank you. So hopefully in a few years, maybe not right now.
Yeah.
Great. Any other questions? I don't see anything. Well, thank you so much for this excellent talk. It was fantastic. Everybody enjoyed this. And thank you everyone for joining. We'll see you next week. Thank you.
Thanks everybody again. Bye-bye. Take care.